Max Knight, a first-year DAT student, joined here with Isaac
Chang, also a first-year student in the DAT.
And I'm Sam Arredondo, first-year student in the ISU DAT program.
All right, and so today we'll be going over some tests for anterior and posterior SI joint dysfunction. These techniques will be kind of corrections. So first we'll do yours first, Sam, since you have a student with you. So.
Cool. All right, so first one I'm going to do is the muscle energy technique for a posterior rotation, so posterior correction basically. Blake, I'm going to put my hands on your SI joint, is that all right? Yeah. Okay, so first thing you're going to do is find the PSIS. Can you guys hear me all right?
Yes.
Okay, so first thing you're going to do is find the PSIS, that's how you can and apply some downward pressure. And then second, you're going to have your patient press up 6 to 8 times. Press up on the knees, and then again, just applying that pressure as they go through the movement. Just go ahead and do 6 reps. And it shouldn't be painful. It just should be enough pressure so they can feel the mobilization, but shouldn't be painful. And again, you do this 6 to 8 reps for 3 to 5 sets, depending on the stage of treatment that you're applying to the patient.
Perfect. Job well done. Any comments? No? Okay. And just to make sure, the hands are on the affected side or unaffected side?
The affected side.
Okay. Cool. All right, so now we'll go with Isaac.
Since Sam just demonstrated the muscle energy technique, I'll do the same thing, just for the anterior correction. Okay, so we would have the patient prone on the treatment table.
My head right.
Yes. You will be, the clinician will be standing on the side opposite to the affected side. You will have one hand placed on the patient's ASIS. Do you mind if I touch you?
Yep.
Okay. And then you will also place your other hand on the patient's sacrum. Okay, and you'll apply a downward force. Okay. And so you would ask the patient, while you're holding the downward force, to do a press up of 6 to 8 reps. Can you do that? Okay, good. 6, last one. Good. Okay, and as per usual with any kind of treatment intervention, you should always start easy at the first, especially if it's in the acute or earlier phases, and start increasing in intensity or volume as the patient progresses. I think one important thing to note with both of these techniques is that the patient's hips need to be on the table. So in cases of people with tight hip flexors like me, if you were to ask me to do a press up, my hips would definitely come off the table. Because it's tight. So one thing you might want to consider is instead of having the patient go all the way to their wrists or their hands, you might ask them to modify it and go up to their elbows instead. I think that's also a good modification if a patient doesn't have full range of motion with torso extension. So yeah. Any comments, questions, concerns? You're muted, Sam.
Sorry, I was muted. Did you say that was the anterior innominate?
Correct.
The muscle energy?
Yeah.
Okay. Yeah, and affected, again, same thing, affected side rather than unaffected side.
Mm-hmm. Well, think it out. Yes. Yeah.
The poster. Okay.
Yes.
Okay. Good.
Sorry, we have to think this one out.
Yeah. Okay, so the next one we're doing will be the direct posterior
Anterior correction.
Anterior correction. So what we'll do is the patient, so we'll be working on Isaac's right side. So he'll be laying on your left side. So go ahead, lay down. Sideline. And so this test is gonna, or not test, but technique is gonna be up close and personal. So, so Isaac, I'm gonna have to put my left hand on your ischial tuberosity, which is right in the middle of your glutes. Is that okay?
Sure.
Okay. All right. So now that I got patient consent, what I'm gonna do is I'm gonna put Isaac's right leg around my back. So do that. Okay. There we go. Okay. So now I'm gonna find Isaac's ASIS. So put my hand right there. Okay. And then I'm gonna put my hand on his ischial tuberosity. Calm down there, Super Chief. Okay. There we go. And then for 6 to 8 reps of 3 to 5 sets, we're going to push against his ASIS and his ischial tuberosity for the correction. I lost count.
8, 6.
Okay. There we go.
Sorry,
You're okay. All right. Any advice, comments, concerns? No?
I think I think I brought this to light in last week's discussion for class. Actually, all these techniques are pretty much pretty important to get patient consent before you, and like inform them what you're doing before you do it because of hand placement. But
one question I have, I guess for you, Sam, since you were the one watching, I guess you too, Isaac, is as far as like the placement of myself with his leg around me, I guess was when I was doing the actual technique, did you feel like there's
for sure.
Okay.
I mean, I think you were effective because you're just bigger and you could actually get the posterior rotation. Like when someone else did it on me, that person was just a little too small, so she wasn't able to quite get the rotation.
Right.
Like, I mean, I felt it, but you were definitely better at doing it because I guess you were just cranking it forward harder.
Yeah, I think you probably it's like again awkward kind of positioning for this one. So, but I think you did. It looked like really. It actually looked completely like the example that I saw. So.
Okay, because Dr. Paladin, I'm gonna give you some props here. I'm gonna pump tires, but it as far as like I was afraid your leg was gonna be like the test wouldn't work out because like your leg would fall or
my right leg.
Yeah, your right leg.
My leg wasn't going anywhere.
Okay, because I would have felt like the patient would have started activating muscles and they wouldn't relax just because their leg might fall or something. I don't know, but yeah.
I mean, I think in that case, like, I know a lot of times, like if a specific technique or an evaluative maneuver requires the patient to be comfortable, you have to say, or like it's like kind of off the table and it's like a danger of falling. You always have to like reassure them, I have you, don't worry, you're not going to fall.
Right.
I mean, if you do that, I think they'll be fine.
Yeah.
I mean, again, I think it's a part of developing patient rapport. So
yeah,
definitely.
Okay. All right. So
actually, before we go on to that, Dr. Paladin was mentioning the exercise that you would do, which was the one with the patient supine and basically them pressing, basically going to hip flexion isometrically. Now I learned like an MET for that, which was basically that, and the other one was the counterforce against the opposite hand.
Yeah.
Have you guys learned it before?
I've learned, that one, yeah.
No, I don't think so, to be honest.
Well, because that's how I was taught to correct anterior and posterior rotations, was just with the muscle energy technique. So this is all new to me. So
see, but then I think that would just go ahead, Sam.
You're talking about using muscle force of like hip flexors and hamstrings. Is that what you mean?
Yeah,
that's what I learned. So
yeah. So
actually, Max is gonna demonstrate it.
So if we do our test and put my thumbs on both of his ASIS, let's say this always puts my mind in a pretzel. But let's say his left ASIS is a little bit higher, indicating a posterior rotation of the left side. So what I would want to do is I'd want to activate So I want to activate the hip flexors to be able to pull or rotate the left side of the pelvis anteriorly. So what I would do is basically I want you to bend both of your knees, okay, and then bring your knee up towards your chest. And what I would do is, depending on the size of the patient, is I'd either have one arm, both arms in between their legs. So I'll just do one arm here. And then so the next thing I'll say will be, okay, Isaac, what you're going to do is with your right leg, you're going to push down like this as hard as possible. At the same time, you're going to be pushing up towards your chest with this leg as hard as possible. So I'll kind of move the hips up. It's close to 90 degrees of hip flexion. And then on the count of 3, I want you to go as hard as you can for 5 seconds. So 1, 2, 3. Okay. Then go, 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 go. Relax. And then I think this kind of, you can set up if you want. I think people do it differently, but I usually do about 3 sets of like 5 seconds of that. And then I was kind of taught just to basically resist abduction and adduction. For that, and then recheck with the what's it called? Test. So yeah,
that's actually what I learned too. And again, I think they're like a really helpful test in actually like measuring where the correction is needed is the supine to long sit test.
Yeah.
And I've never heard of that test before this class, and I think that really helps to really identify what specifically you can do and really be efficient with your time and your treatment. Like if you know, like if you do the supine to long sit test, and then you see that somebody's got an anterior rotation of their right hip, you know, you can correct that using these techniques, either muscle energy or direct.
Yeah, exactly.
Corrections. So I think they're a little more clinician friendly, because you don't have to, like, especially if you're doing it with like a larger person and you can do muscle energy, like that's fairly simple using their force and your force, rather than just resisting, like, for example, like my patient panel is like, you know, like a 250-pound like football, like a linebacker or something like that. It's like way too strong to possibly create an actual effect.
Exactly. Yeah. All right. Ready for the last one?
Yes.
Okay. Let's do the last one. So I'm gonna botch the name of this. So the last one is a direct anterior rotation correction, right? No,
posterior.
It'd be a posterior correction, and
Yeah,
towards the anterior direction. Goodness gracious. Okay, so again, Isaac, I want you to lay face down on the table with your head at that side of the table. And so let's say the left side of your hip is the affected side. So what I want you to do is kind of slide towards me a little bit so your right leg can hang off the table. Okay. And so my hand placement with this is basically I'll start by putting my hand on his thigh just above his knee. And then I'm going to put my hand on his ASIS, or no, his PSIS. Sorry. And then what I'm going to do for about 6 to 8 reps of 3 to 5 sets is basically, relax. Are you going to fall off the table? No. Okay. is basically lift this hip up and push down. Okay, and then wait like 30 seconds and then apply it again. So, any comments about my technique or the technique in general?
Ask for consent, Max.
Oh,
What? What did he say?
ask for consent.
Oh, ask for consent. He established consent already prior.
Okay, previously.
I think
Good point, though. Good point.
one of the clips I have with anything involving the PSIS is considering that. Sam, how long have you been practicing for?
4 years now.
4 years. Okay. So we are both brand new spanking clinicians, right? And so according to an article in the Athletic Training Education Journal, novice athletic trainers are really unreliable when it comes to palpating lumbar, abdominal, pelvic, bony landmarks. So anything wrong with the PSIS, I'm like, are we actually do you think it actually matters that we're getting the PSIS or accurately right on it or not? Because chances are we're probably going to be missing it most of the time. We're not reliably performing it. So what are your thoughts?
That's I mean, if you're missing, so the PSIS, I don't think is, I mean, it's not as precise a point. Like the ASIS, is super easy. If you're missing the ASIS, there's a problem, you know. But I think the PSIS is more of a broad,
General area.
Yeah, because since the the posterior sacroiliac joint, if I can speak, is so broad. I think if you're as long as you can distinguish between the sacrum and the ilium, and you're not pressing down on the sacrum, you're pushing down on the ilium, I think you're gonna get done what you need to get done. Because the PSIS is kind of, it's not there it is. I think it's more of a broad anatomical landmark other than the ASIS.
Cool. So I have a few quick questions I wrote down a few days ago. So as far as these techniques, how have you guys seen these before, or are these kind of new to you like they are to me, or do you use them often?
Oh no, these are completely new to me. I mean, Isaac said, I've been practicing for 4 years, and I know the muscle energy technique that you guys actually demonstrated. I've done that more times than I could even tell you. But these ones are fairly new.
Yeah, and I'm actually kind of glad we were exposed to these, because sometimes I wonder how effective I am personally with muscle injury technique like the one we demonstrated. So I mean, I think that may be my go-to, the first thing I'll do if I want to try and make a correction. But I mean, if I don't see change I want, then I have an extra tool in my toolbox to do that. So,
well, going back to what you said about METs not being effective, I know we've been taught, all of us or some of us been go as hard as you can, but technically if you look at the literature, or at least what we've seen 2 weeks ago, it's only 20%.
Yeah.
So
that was a major point for me. When it came to muscle energy technique, was really focusing on a 20% maximal isometric contraction. I had muscle energy for hips, go as hard as you can. At least that's what I was taught, when that's not exactly true muscle energy technique, so I think these ones, I think these are a little bit more accurately named rather than those ones. And again, I think I would rather use these rather than the really, because the other technique that you guys demonstrated is so general, it's not a specific correction. It's I think you can I mean, if something's anteriorly rotated and posteriorly rotated, then you're like doing them both at the same time, right?
Right.
I think these are like more like, and I think the past 2 weeks we've gained in like more more skills, like evaluative skills, to actually determine what the dysfunction is or what's causing the dysfunction, and then being able to correct it appropriately.
Now, with these techniques, even though they're called METs, like I don't feel like they're quite METs because usually, like if it's an MET, you're applying a force and a counter force. Like I don't see where the distinction is between the two techniques today. It seems more like a mobilization movement because you're applying a guard and having the patient do movement, right?
Yeah, kind of like a Mulligan's.
Yeah.
Right. Yeah.
So I don't know. Like I guess it's an MET because we're calling it, but
Yeah, I'm kind of definitely siding on your side of the argument there. Like especially like with the tests you guys did. I mean, the only thing I did was just press up. And the only thing your student did was press up. So I wasn't using my glutes or my hamstrings or anything. So yeah, that's
just
I'd like some feedback about that, please.
You're so sassy.
I'm just saying.
You're nasty.
No, I think that's a good point, because muscle energy takes some sort of, by definition, is like either a reciprocal inhibition or a voluntary or a submaximal isometric contraction. So, and it wouldn't be submaximal isometric contraction the way you do it. And I don't exactly see that being reciprocal inhibition either. So yeah. Yeah, I think maybe, I don't know, maybe a Mulligan's mobilization with movement is probably a little more accurate. Dr. Powden, thoughts if you get this far in the video? Yeah.
So kind of like a little comment I had was, like I know I literally just said, I'll probably use MET like we showed first, but I think from the actual testing we learned last week and the techniques used to treat the patient now, I think it's kind of it should probably be our first thing to go to, just because the test, like as far as thinking about the patient and being in the patient's shoes, the testing like is very similar to the actual or corrections. Like the hand placements are similar, and it's like if I were the patient and say Isaac was palpating the ASIS, the PSIS, and then he does muscle energy technique with his arm between my knees. I'm like, okay, well, like what's going on? I'm just saying, like last week and this week, it's just familiar stuff. So I feel like the patient wouldn't be like, oh, like what the heck? Like you're looking at my hip, and now you're dealing with the knees. Like what's going on?
You're saying the evaluative techniques and the treatment techniques are basically similar.
Yeah.
Okay.
They're complementary to each other.
Yeah. I definitely see it.
Yeah. So.
Hold on, I can't hear you. The ice machine actually just kicked on, so I'm gonna move over here.
Nice. I have a question. So, in the reading, it talked a little bit about MRIs and diagnosing SI joint dysfunction. And it has low sensitivity and a high specificity, or of SI joint syndrome, excuse me. When would you go for an MRI for this? Because I feel like it'd have to be a very, 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 very chronic issue or something you just can't figure out. Which I don't know. I mean, I feel like you could be able to figure it out in the clinic, but I feel like it'd be more of a luxury thing. But
yeah, I would probably agree with that. I mean, I think if you had like, if somebody has severe like neurological symptoms that are acute, I think that's when you send them to an MRI. I mean, you could like rule out a herniated disc, but then again, I don't know. It's hard to say, especially at the Division I level. If somebody comes in and says like severe sciatica and like has like numbness, tingling, like all the way down their leg, or inability to like, or like abnormal bowel movements, something like that. That's, I mean, we almost can get an MRI for that. But when it comes to like, for example, like SI pain, I actually have, okay, I actually want to bring up like a patient case into this. So I have a patient that's had like SI pain for, actually he's a freshman, and he's had SI joint pain off and on since his 7th grade year. So yeah. So he went to PT in high school, and not a lot of resolution, and he played all season last year and hasn't really had any issues until about January. And so I'm actually glad that we're going over this stuff, because I haven't exactly used any of this stuff on him, because I feel like I hadn't had enough information until probably these last couple days to actually apply these techniques. But so I think this upcoming week, if he doesn't see a significant change, I think we're looking at getting an MRI. So that kind of answers into your question. And I think the biggest thing is like, if it, like in my patient panel, like it's in my at my job, it's relatively easily to get MRIs. In the high school setting, it's probably not so much, obviously. And I think if somebody's not having a resolution of their symptoms, probably within, or at least an improvement of their symptoms in at least 3 to 4 weeks, probably closer to 4 weeks, if they don't have some sort of resolution or improvement, I think that's about the time when you start to consider looking into diagnostic imaging. And that goes to like kind of the complex SI joint treatment algorithm, which I'm pulling up as we speak, because imaging is on there. If you don't have, it takes me forever to pull these up. Yeah, so if hips are ruled out, hip, low back, mechanical hip pain, mechanical low back pain, and mechanical SI joint pain are all ruled out, then that's when you go to imaging. And at that point, I would assume that you've probably ruled out all 3 of those, hopefully by 4 weeks. I mean, if you're not doing a full evaluation again, I mean, you're taught in class to do the joint above and below, and that hips are so complex that you need to look at everything.
Yeah. Well, speaking from like working in a similar setting as you, by that point, if it's that chronic and you're not getting some resolution, you probably refer anyway.
Yeah, true.
So like, I mean, I don't think it's something that we necessarily have to think about, like Sam was saying.
Yeah. Good point. Yeah. Yeah. Any other thoughts or things you didn't like about the techniques we learned today, or not today, but this week?
If I were to do the anterior correction, like I would have a hard time like you, especially if we're doing the direct one. Because, again, if I have a 300, 250-pound leg and me, like, and if they're tall too, like I'm gonna have a hard time with that. So probably not likely to do the direct line. I mean, if it's like a track athlete, like, and he's skinny, or he or she is like skinny, whatever, that's fine. But I think.
Well, so that made me just think about like for that test, if you were to have a larger person, I mean, would you be able to generate, I guess, more torque if you were to say maybe put like the base of your elbow, kind of in that direction, and then still be, or no,
but
maybe
it would still be hard to crank them up.
True.
Yeah, because like,
Yeah.
I mean, if you're thinking about it, like just trying to do a prone hip flexor stretch on them manually is hard enough. Like I have to do that, and then on top of applying the counter pressure, we just So like I would probably not do direct methods with heavier bigger people than I am.
If you had, and this is just another idea, if you had like one of those green, like kind of canvasy, like stretch bands.
Oh, like the yoga
Yeah.
bands, and then have them do it.
Yeah, they put themselves into hip extension while you press.
Okay, that's a good idea.
Yeah, I don't know how well that would work, but
I mean, as long as they're strong enough to do it themselves without activating anything else. But I think that's a good idea.
I think the other thing that I always think about this, especially when it comes to these joint corrections that we've been going over, these SI joint corrections. Like in my setting, I'm really fortunate to, be around the same group of patients like daily. Like that's like the 100 or so people that I work with are like, that's it. Like that's all I have to deal with. Not and only one sport. And I'm fortunate again enough to have 3 other clinicians that work with me to be able to see my interactions with patients. I think what makes these joint corrections more difficult, like in your guys' setting, like in a PT clinic or a high school, is like, first of all, if you're dealing with minors, and like if you're the only athletic trainer at a high school, if you're dealing with minors and you like have one patient, the one patient that needs these corrections, like in your office, like if you're going to do a direct anterior correction, I think it's
Like
a little, what's that?
He said, she said.
Yeah, exactly. That and dealing with that age of patient, due to maturity or lack of maturity, or just I don't know. I don't know what I'm trying to say. I guess it's more awkward to deal with that patient panel than it is to me. Like I could see myself doing these corrections like tomorrow, for the patient that has had the SI joint pain. I think the more challenging part in the high school setting is to find an appropriate time and place, and hope that you have another clinician or other patients around, or students. That you get it, and your patient education is good enough to understand, like, hey, like this is what I'm looking for, this is what I'm doing. And I think that's probably the most challenging part. I think the application isn't so much the hard part. I think it's the consent part and the theory behind a lot of these, to be honest.
Yeah. Yeah, I think just like a way to combat that is just kind of playing the political route, like going around the school, making sure they you're making a presence at practice,
Yeah.
having that rapport with coaches,
Just so they
right, being able to educate that patient, well enough to where you're not dumbing it down too much, or you're not talking so philosophically about it or sophisticatedly about it. It's easy for them to understand. They and also, like, I'd say, like, you can plan this out ahead of time, where you let the coach know, like, hey, I need to see this person for treatment during practice, and hopefully your coaches, if you guys have a good relationship, they're like, yeah, sure, whatever. But you need to make sure, like, hey, I'm gonna need like so and so as well, just so you have that kind of witness.
Right.
So,
Good point.
yeah.
Awesome.
All right, yeah, this was a really awesome discussion. So, nice job, everybody, and thanks for watching.
See you later.
Oh gosh, hold on.